Hello, I'm Joanna, Jacques, an accredited exercise physiologist working at Macquarie University Hospital in Sydney, Australia. Thank you to ImpediMed for inviting me to contribute to this international webinar series, Health is Fluid. Thanks to Lee and Adam for explaining the finer details of bioimpedance technology for body composition assessment. Last week, it was also great to hear from Brent Collier and Robin Box talking about the important role which exercise can play in optimising health for our cancer patients. I'm going to be talking about my experience in implementing body composition assessment using the SOZO device in a multidisciplinary allied health setting. There is growing evidence linking measurements of body composition, including fat mass and muscle mass, to important indicators of health, function, and quality of life in both healthy individuals and those managing a range of clinical conditions. As a result, we are seeing growing interest from health professionals and clinicians in being able to assess and track the impact of their interventions on these measurements. Increasing evidence tells us that traditional measurements such as BMI may be inadequate to pick up patients at risk of poor health outcomes due to low muscle mass or excessive body fat. Although BMI has been a really useful tool to measure health risk at a population level, it doesn't take into account the individual patterns of body composition nor the distribution of body weight, which are known to vary significantly. Many factors are known to impact on individual body composition, including age, gender, cultural background, along with modifiable factors such as nutrition and physical activity patterns. For example, with healthy aging, we see a common pattern of body composition change, including an increase in visceral or central fat mass, reductions in lean body mass, and reduced skeletal muscle mass and function. Studies in clinical populations have also demonstrated body composition changes associated with disease and treatment. For example, in cancer patients, low muscle area has been demonstrated in up to 28% of patients and has been associated with a range of poorer treatment and survival outcomes. Exercise and dietary interventions can impact positively on body composition patterns, such as increasing lean body mass and reducing body fat. Therefore, as a clinician, being able to measure these changes is of great interest. Two of the common body composition changes we are seeing in clinical settings are sarcopenia and sarcopenic obesity. Sarcopenia is defined as low muscle mass and impaired muscle strength and function. This can occur naturally as the result of the aging process and is also seen in patients with a range of medical conditions such as cancer, metabolic and cardiovascular disease. Common clinical assessments of sarcopenia have included measurements of grip strength and functional capacity such as chair rise tests, together with percentage weight loss changes. Interestingly, we are seeing a combination of two body composition phenotypes, termed sarcopenic obesity. This is a combination of low muscle mass and function, together with increased fat mass. The coexistence of these two patterns presents a double health burden, with increased risk of physical limitations, disability, and cardiovascular and metabolic disease. Sarcopenic obesity is often hard to pick up with measurements of BMI alone, especially in obese patients. Therefore, using a combination of body composition assessment together with traditional clinical assessments can assist in the early identification and management of these patients. I've been fortunate over the past 2 years to have access to a SOZO device within the multidisciplinary weight management and oncology clinics we deliver within our private hospital setting. The SOZO device has enabled easy integration of body composition assessment into routine clinical care for our patients, alongside with our existing clinical tools and approaches. Within our multidisciplinary allied health team, we have an accredited practicing dietitian who undertakes nutritional assessments and provides individualised dietary plans. We have an exercise physiologist who reviews current physical activity levels, assesses functional capacity, and prescribes individualised exercise programs. Both allied health professionals deliver education and health behaviour change counselling, together with individualised psychological support when required by a clinical psychologist. As allied health professionals, we are supported by a team of endocrinologists who review and prescribe medical therapy to support metabolic health and address various comorbidities, and also a bariatric surgeon who undertakes surgical weight loss procedures. We have a wider multidisciplinary team within the hospital, and this includes physiotherapists, lymphedema therapists, nurses, and a range of medical specialists, including oncologists and cardiologists. Echoing the points which I've heard earlier in the webinar series, the tissue analysis outputs from SOZO have proved to be a useful clinical tool in a number of ways. Firstly, to undertake baseline and serial health measures. We routinely include a baseline measure of body composition, including fat mass, fat-free mass, and skeletal muscle mass in all of our weight management and cancer patients who attend the clinics. Together with our traditional clinical measures, such as weight, BMI, waist circumference, and measurements of function and nutrition, these measurements help to paint a more complete picture of body composition and health status. We continue to collect these measurements at each review visit, which is usually monthly, and after completion of a specific intervention. We share this information with our patients and also with our multidisciplinary team. Secondly, as a patient education and engagement tool. So discussing the tissue analysis results with our patients has been useful to open up discussions regarding body composition and health, including weight management, addressing strength changes, and protein needs. We've found that patients like to have a number or some objectivity around body composition, and they feel more engaged with the process of monitoring these changes over time. It's been positive for many patients living with obesity to move away from a weight loss only target to look more closely at body composition, functional and health measurements. Thirdly, the SOZO has been useful to tailor our exercise and dietary prescriptions. From an exercise perspective, reviewing a patient's baseline fat mass and skeletal muscle mass, together with measurements of physical function and their health goals, helps to determine the balance of aerobic to resistance training and the relative intensity of exercise that we would prescribe. Over time, the impact of the exercise intervention on these measurements can be reviewed and the prescription adjusted accordingly. With time continuing to be one of the greatest barriers to exercise, I often find it useful to discuss the relative importance of one type of exercise over the other and the division of time that a patient may spend across the week. From a nutritional perspective, our dietitian uses the measurements around basal metabolic rate together with physical activity levels to help to determine appropriate calorie deficits and targets for weight loss and intake. In our cancer and post-surgical patients, measurements around fat-free mass and skeletal muscle mass have been useful indicators of nutritional adequacy together with traditional monitoring of protein intake. If these indicators are not moving in a positive direction, a change in the dietary plan or the use of supplementation may be considered. Our dietitian also finds the HYDEX measures of hydration status to be a useful tool to educate and motivate patients to make changes in their water intake. As with other SOZO measurements, our focus has been on achieving positive changes within the individual from their own baseline. In this case, in the case that these measurements are not improving with exercise or dietary intervention in the desired direction, we then consider referring back to GPs or medical specialists for further investigations. The tissue analysis outputs have also been an important outcome measurement. So together with our traditional clinical and functional measures, we are using these results as outcome measurements for both our patients and our multidisciplinary team. From a patient perspective, weight management goals are often discussed in relation to a rate of weight loss, together with positive changes in fat mass and a maintenance or gain of skeletal muscle mass. This has helped to maintain a focus on healthy and sustainable changes for our patients. From a team perspective, measurements around fat mass, fat-free mass, skeletal muscle mass and total body water are shared amongst our team as a clinical outcome measure. We're also collating this data for future research purposes and we're seeing increasing interest in the literature in reporting body composition changes alongside traditional weight loss changes. Finally, as a referral indicator, so the SOZO has also provided an easy tool to screen for other changes in health status, which may benefit from investigation or referral within our multidisciplinary team. So for example, in our cancer patients, LDEX scores are routinely collected and reviewed for referral onto our lymphedema team. Other changes, such as significant shifts in fluid volume, are flagged for further investigation and review with our medical team. We're also looking at identifying referral indicators for our exercise physiology, dietary and weight management services based on a combination of traditional clinical measurements and body composition. And hopefully this will aim to have patients referred earlier into our services within the hospital setting. To demonstrate our implementation and use of SOZO for tissue analysis, I'm going to share a case study of a patient who was referred to our multidisciplinary weight management clinic. This patient was a 46-year-old female with a starting weight of 130 kilos and a BMI of 45.7. She'd struggled with her weight since childhood and tried a range of lifestyle and medical approaches with limited success in sustaining weight loss. She was an emotional eater who presented with limited other comorbidities, and her primary motivation was to improve her health and feel better about herself. So following our initial multidisciplinary assessment, this patient elected to undertake surgical weight management through a sleeve gastrectomy to achieve a significant and sustainable weight change. SOZO tissue analysis measurements were taken at the initial assessment, pre and post-surgery, and throughout the following 18 months to monitor body composition outcomes and also to help tailor the exercise and dietary prescription. So the graph displayed on this slide demonstrates the overall body weight changes that were achieved in the 18-month period, from a starting weight of 130 kilos to a stable 80 to 82 kilos at 12 months post-surgery. The next graph picture demonstrates the changes in fat mass, which were achieved over the same time period. So these changes closely mirrored the overall changes that we saw in body weight, with a rapid loss of body fat seen in the initial 6 months post-surgery, which then tapered off and stabilised at 12 months. In terms of skeletal muscle mass and fat-free mass, we saw variable changes there. And the SOZO was really interesting in terms of being able to monitor these and specifically tailor our nutritional and exercise interventions. So you can see in the early post-surgery period, there was quite a rapid loss in skeletal muscle mass, and this is quite commonly seen in our patients. So early nutritional strategies included monitoring of calorie and nutrient intake through an online app with a focus on ensuring adequate protein intake. In the early stages post-surgery, this can be difficult for patients to achieve with rapid changes in the volume and types of foods which can be digested and absorbed. We found the SOZO measures to be useful objective indicators of nutritional adequacy in combination with tracking of dietary intake. Exercise strategies to address this loss of skeletal muscle mass included early inclusion of weight-bearing activity in the post-surgery period and body weight-loaded strength exercises. With continuing drops in skeletal muscle mass at 6 months post-surgery, we decided to change the exercise prescription to a gym-based strength program at moderate to high intensity, together with commencing some short intervals of jogging exercise. So again, here the tissue analysis measurements provided an objective measure of the effectiveness of these strategies and assisted with decision-making regarding the specific exercise prescription. So as you can see in the graph, the combination of a nutritionally adequate diet and regular moderate to high intensity resistance training brought about really positive gains in skeletal muscle mass around that 6 to 12 month mark. Which we saw were then maintained by the patient. So this was very encouraging feedback for the patient to see and something for us as a team to monitor over time with our ongoing sessions. Alongside tracking changes in individual body composition, we often discuss with patients a healthy weight range or body composition targets using the overall results chart. So in the case of this patient, her lowest weight of 79.4 kilos equated to a BMI of 28.1 and represented a weight loss of around 40%. So look, we were naturally very happy with this result, but the patient was keen to go further and to know what would be considered a healthy endpoint. So in this case, we really went back to the body composition targets and looked at the percentage of body fat and skeletal muscle mass to work towards in the future. So with this patient, we agreed a target of continuing to reduce body fat towards 30%, together with maintaining skeletal muscle mass, and also seeing further gains in her functional strength through some of her specific resistance-based exercises were appropriate health targets. And these were goals that we could continue to measure over time and were independent of her weight itself. My second case study involves a 55-year-old female undertaking treatment for stage 2 breast cancer. She was referred to our exercise physiology service by her oncologist and breast care nurse 2 weeks following diagnosis, and was seen across her treatment pathway, which included neoadjuvant chemotherapy, surgery, a lumpectomy, and radiotherapy. The exercise intervention included a home-based walking and bodyweight loaded strength program during chemotherapy, with transition to a supervised exercise training program undertaken at our on-site clinic during radiotherapy. She really is an ideal example of early intervention and the positive role that exercise can play during cancer treatment. So SOZO measurements, including tissue analysis and LDEX, together with traditional measurements around functional capacity, activity, and symptom profile, were taken at each review assessment and assisted with education and guiding the appropriate treatment plan. So pictured on this slide are the weight changes seen across the various treatment phases for this patient. In relation to body composition, despite a drop in overall weight during treatment, we saw variable changes in fat mass, which were actually consistent with our measurements of waist circumference. So after chemotherapy, we saw small gains in fat mass, and we were then able to achieve some reductions following completion of radiotherapy. So whilst undertaking radiotherapy, we assisted this patient to increase the volume and the intensity of a physical activity that she was undertaking through participating in our on-site supervised exercise program, together with a home-based walking program. This patient also received some education and support regarding healthy eating habits. And she mentioned to me that she was more conscious of making some better eating choices. So I think the combination of exercise and some nutritional awareness contributed to the positive body composition changes that were achieved. In relation to fat-free mass, we saw more marked reductions during chemotherapy. However, with closer analysis of the skeletal muscle mass component, this remained relatively stable across the treatment period. And this was a fantastic achievement, as a number of studies have really demonstrated a loss of skeletal muscle mass during chemotherapy, which does negatively impact on a whole range of outcomes. So this was positive for the patient to see, together with improvements in her physical function, and really helped to reinforce the benefits of staying active during treatment and continuing with exercise over the longer term. At the end of the supervised exercise program and radiotherapy, we reviewed and discussed the overall weight and tissue analysis results with this patient. So her weight of 65.1 kilos just fell within the healthy weight range with a BMI of 24.8. However, closer look at the specific tissue analysis results indicates a higher than ideal body fat percentage and a lower relative skeletal muscle mass percentage. So there was definitely scope to further improve her body composition and health profile. So we were able to use these results together with our other clinical measures to discuss healthy lifestyle goals following treatment, tailor her ongoing program and set some targets to review in the future. So we did discuss referral to our dietitian for nutritional support for body fat reduction in combination with an ongoing home-based exercise program. So the exercise program goals were focused on both increasing the volume of her moderate intensity aerobic exercise and continuing with a strength-based program for maintenance of lean body mass, joint stability and bone health. We also reviewed LDEX over the treatment period, and this remained relatively stable throughout treatment and would be something that we continue to monitor in our follow-up visits with this patient. So to summarise, the tissue analysis functions with SOZO have proved to be a really useful clinical tool to supplement our traditional outcome measurements of weight, functional capacity, and nutritional adequacy. This information has been useful to our allied health clinicians to tailor exercise and dietary interventions and to measure their effectiveness. From a patient perspective, the tissue analysis outputs have been useful for education and as a behaviour change facilitator. For our wider multidisciplinary team, the SOZO assists us to communicate, identify other clinical needs and implement early referrals. Thank you very much for your time, and I look forward to hearing from you if you have any further questions.